Hello, everyone. Welcome to the Para Podcast. This is where we discuss matters that are related to EMS in Africa and the world at large. What we try and do is bring whatever is happening in the world to Africa and also try and discuss matters, especially around EMS in Africa. And we try and have conversations around this, what our thoughts are, share our sentiments, and sort of try and progressively discuss and grow a portfolio of topics and also discussion points. So today we are covering a newsletter that was released by the Professional Board for Emergency Medical Care in South Africa. And we wanted to share your thoughts, our thoughts actually, and try and discuss around what covered. And then also try and see how that pertains to what is relevant now in EMS, especially in South Africa and nearby boundaries like Botswana. We do have quite a huge following from Botswana. So thank you to everyone
Shout
else that
out to
watched
Botswana.
Botswana. Shout out to Botswana. Hopefully, we can have you guys soon. We are absolutely delighted to have your numbers. We see the numbers. Guys, we do see that about 85% of you are not subscribed yet, but you do watch the content. Please do subscribe. We really appreciate it. It allows us to keep producing this content and keep us motivated. So, with regards to this, I am joined by Tulani as per usual, and I have Malusi. Malusi is actually on holiday right now. That's why you see a different background and a new look to it. And then, yeah, Tulani is in his usual comfort zone. So, Malusi, when you saw this, what were your thoughts when you saw this newsletter that came out? What did you think?
I'll tell you. The first thing I thought, oh, another thing to read.
Yeah.
And then I browsed through it. Obviously, we have to align with what the council want us to do. One of the ways that they communicate is through newsletters and yeah, so I had to read it. So I firstly browsed and looked at the topics that are covered. I think what quickly stood out for me was the gun story. I was like, oh, we're talking about guns again. And then also the unprofessional conduct, as you see it there, in the front, and then the CBDs. I think we've spoken about CBDs. I think those things they popped out like, I wonder what is it about. And then yeah, so it's a different story once I started zooming into it and starting to read some of the matters and stuff that I've seen before and that they've discussed. So I was trying to understand the document exactly what's happening with it. So yeah, it was good to get updates and to see what's happening and where is the mind of the council that regulates us as ambulance clinicians.
Professionals, yeah. Talking about CPDs, actually having something cooking in the pipeline. Hopefully, we can bring it to our viewers very soon so that they can get points for whatever they watch. So hopefully, we'll announce it soon once it's official. We are very excited for it, and we look forward to announcing that part. Tulani, what did you think? What was the first thing that sort of caught your mind within this newsletter? Besides, it being backdated and so forth, tell us what did you see?
I think the thing is a lot of the stuff that might still be maybe published in other places or it might be published by the HPCSA in one of their platforms. However, it's quite what stood out is that till today in 2025, we are still encountering those challenges. I mean, the unprecedented attacks on emergency care providers, and it's not just in South Africa; it's global, everywhere. It's still the talk of the
It is.
town. What also stood out for me is something that they mentioned, and we'll maybe dive deep into it, is with regards to CPD. Um, and it brings a different views that one of the things they said is that emergency care providers shouldn't see continuous professional development as a punitive system, but also where do you draw the line? If it's not punitive, it shouldn't be punitive, but also it needs to be ensure that practitioners keep up to date with the latest treatment, and there is a reason why that's supposed to be done. So it's a fine balance that the profession is trying to have. But also, what was interesting about this is the when it's in relation to the firearms. Should emergency care personnel be carrying firearms? For instance, I'm not into firearms. I'm too scared of guns.
You can't
And
use one.
yes, some people say guns kill people, but it's usually people that kill people with guns or ammunition, whatever that they use. And yeah, those were the things that interesting also is that it was interesting to read about the fact that how can we lodge a complaint against health practitioners? Is it something that is happening amongst practitioners? And understand that when you lodge a complaint against the health practitioners, it shouldn't be something that is personal. It should be to protect the patients, to practice ethically, to make sure that we uphold to the ethical standards. But those were the things that stood out for me.
No, amazing, amazing. I think it's quite. We are gonna be running through sort of like each and then sharing our thoughts on it. But and thank you for highlighting those guys. I think the thing that possibly stood out for me again is probably the firearm bit. And I think this is something that has been debated along the lines everywhere in the world, as you guys have highlighted. And I think it's a very interesting point, and you're gonna dig into it. So, and then I guess just the CBD part, especially to say, try not to purchase certificates. It seems like it's a well-known fact.
But how do you do it? Like, I've never thought that I would have to buy a certificate for CBD. I mean, it's easy to get them. Most of them are free. I don't get that. Well,
Sounds like
people do it, I suppose.
sounds like there's a very lucrative business out there, like the PhD shop that I saw somewhere. I think
In
someone
India,
advertised.
that was in India.
Then there is a CBD shop that is running somewhere. So that is sorry, a PhD shop. So it's very
No,
interesting,
I saw that.
So that would be very interesting that people still do sell certificates. So I think the very first thing on the newsletter, sorry, is gonna be decision tools for emergency care providers. I think that's the first one, isn't it? Before we get
No,
to
it's
lodging
not.
complaints. Let's look at
I'll tell you. I'll
oh
tell
no, the
you
duty.
yeah.
Yeah.
That let me speak to it, Elias.
Yes.
If you read the second paragraph, I highlighted it here when I was reading. Second
Mm-hmm.
paragraph, sentence number 2. It says that first paragraph, second paragraph says all health practitioners, including interns, students, have a duty to always act in the best interest of the patient. A duty is both a moral and a legal obligation. Very important there, those two, moral and legal obligation, to do what is expected as a healthcare practitioner. Refrain from conducting acts that are contrary to the general well-being of the patient interest, either in the personal, social, professional, or political spheres of life. That is a big responsibility. It's
Yeah.
a big responsibility. It made me reflect when I was a student, hearing people that they've done this skill and that skill, and then you start looking for opportunities for doing those skills. And then you think, who are we serving? Am I serving myself, or am I serving the patient here? Am
The
I doing
patient.
the skill because the patient needs it, or otherwise? How do I prove it? I remember when we used to give morphine back in time. Am I giving morphine because it has to reflect in the paperwork so that there may be a less charge so that the company gets more money? Or I'm treating the patient because the patient is going to ask, do you have pain? You're going to be asked, do you have pain? And the patient says yes. But now the quality of pain did not always reflect the the analgesia that is giving. It's giving morphine for a minor scratch, or something that is minor, So all those things made me think about all those things back in time that I used to find myself in those moral dilemmas. What do I do, And now for people that might not have a lot of experience, what do they do? Do they just report that and let the HPSCA deal with it? Or they confront the people and stuff like that. So those things, I think it's a big responsibility, but it's also what we have to try and embed in our practice as the standard practice, that this is what we do. We are responsible and understand that it's a moral responsibility and a legal obligation.
Yeah, and I think also just to stress that it just does not stop within your personal capacity, but even in your social activities that you're doing in any other spheres of life, technically that you are in, it kind of reflects on you. So perhaps it's just something to remind our brothers and sisters that are working out there to know that, just be cautious and be vigilant as to everything else that you're doing. Tulani, do you have anything to say on the professional contact part?
So, with regards to the professional conduct part, is that obviously the main thing is with that is that as emergency care providers or as practitioners, whichever term that you decide to use, is that we always have the moral obligation first to act right, to act in the best interest of the patient, but also there's a legal obligation to always act in the best interest of the patient. HPCSA is one of the professional bodies that we have. It's a professional body in our profession that helps us to uphold professional and ethical standards. But also I understand, we need to understand that this moral and ethical, more of the ethical obligation to protect the patient's care, to protect patients' rights, it is deeply rooted in the Constitution, whereby we have to treat everybody with fairness and treat them the way. So I think that for me, is that I'm sure we've seen an ethical practice, but have we reported it? Have we addressed it? I'm not sure. Back then, I'll be honest, is that when you're still new into the profession, you didn't know what's right and what's wrong. But as you grow older, you start addressing those matters to say, okay, guy, what you're doing, it's not right. Some of the people that when they have unethical practice, you never see them again. You see them once and then you never see them again. But I think the main context of this is that, as always, as practitioners, we have to abide by doing what's right for the patient, ethically. For me, I would feel bad if I had to treat someone and I didn't abide by the ethical for myself, that ethically, and also the following the constitution or the laws of the country that you're working for.
Yeah. I wanted to add there, Elias. If you read the first page to the second column on the side, it says Rule 25 places a duty on every healthcare practitioner to report any alleged, unprofessional, unethical, illegal conduct committed by a fellow registered healthcare practitioner. So everyone has a right. You read that document and you'll see what's happening. But then it doesn't only limit it to clinical practice. If you look, the typical example relates to CBD fraud, and then it goes to the CBD fraud as something that people do, one of the things that I thought of, there's a gentleman that has published a lot around the space of, I think it's clinical governance. It's Ian Howard, if I remember his name. He's published a lot around that space, and I think his research was mainly around that space. And he talks about, I remember reading his paper at some point in life, where he was talking about things that lack within the EMS system, that we do not have systems that actually do the clinical audits, the quality assurance measures. We don't have the proper clinical measures. If you look at it, we have the HPCSA high up there, and then we have a lot of practitioners on the ground. And we expect the HPCSA to look after everyone that is there. Whereas if you look at the other organizations, those clinical governance issues will be going directly to the organization, and then they will manage them at that level, and then issues will be resolved there. Whereas in this case, you have every practitioner has to report to the HPCSA. I think that thousands of people that would be reported. I think it's those issues. We do need to have a lot of clinical governance structures that are, I think, an organizational level as compared to just the HPCSA only being the people. Because sometimes you find that organizations, most of the time, they have their own interests, and therefore they won't report some other matters as expected. So that's what I think.
Yeah, just with regards to that as well, I think it's worth commenting on CPDs and sort of like, because I remember with London Ambulance Service and with St. John's in New Zealand as well, that it was the organization's responsibility to ensure that you do a specific amount of activities in a year towards your professional development. Now, I do know that in South Africa, it's the HPCSA that sort of like regulates how many points you accrued and so forth. Who do you think should be responsible for ensuring that you meet the CPD points required for the year? Should it be the HPCSA, or do you think the employer has a role to play in there? What do you guys think?
So if I can go first, is that, and this is, I think it needs to be a collaborative effort between the practitioner individually, but also the employer. But most of the owners should be on the practitioner themselves, to keep track of their own CPDs. It should be, I think they do mention it in the document, is that it should be self-directed. I forgot they mentioned the 4 things on the document. But as an individual, it should come out from you to say, hey, I need to be responsible for my CPDs. And therefore, also the employer has a role to play to ensure that people ensure that the employees are, what's the word? My English data bundles are finished. But is that people remain compliant, and therefore people will try and remain that. I'll think of those words, but I think it's a responsibility from both. Obviously, there's challenges from some of the practitioners, but also there's also challenges from the employees. From the challenges from the practitioners themselves, is that one of the things that would affect them is that it should be, I think the word that they used, it was self-appraisal. Now, self-appraisal would relate to the practitioner themselves taking that responsibility to reflect on themselves as an individual to say, these are the CPDs that I need, or these. I think when you say these are the CPD points that I need, it's incorrect, but it should be, these are my shortcomings, these are the points, or these are the subjects that I lack in, these are the points where I need improvement in. Let's say you do a cardiac arrest case. Once you've done that cardiac arrest case, you realize, okay, I've got shortcomings in X, Y, and Z. How do I address that? I attend a course. I maybe ask someone else through formal channels to provide me a course. However, there's cost implications which might be affected to that. Also, employees must also have an organization, have an organizational responsibility to make sure that they also offer CPD activities to employees so that they can also be compliant. I think that's my 2 cents. And this stuff that I've highlighted is that it's stuff that is in the document that we are discussing.
Yeah. I think also, as you are talking now, I'm thinking of at least 2 organizations where each and every intubation that is done out of hospital is something that is audited. But now it's 2 ways. You as a clinician, you are going to do all you can to ensure that things are done correctly during your skill. And then you document things correctly. That's your responsibility. And then the second part will be the organization ensures that the skill is done correctly. You see what I mean? So in that way, it's 2 ways. And also, I think one of the issues that I see when I read the document, remember that it says you must report people that are doing something that is unethical. The issue is that sometimes I remember back in time, people say, I'm going to report you to the HPCSA when you do anything. Like you'll be on the road and someone will be threatening you for that, And sometimes at that time, you are thinking about patient treatment and you're thinking at the same time, there's a person who's making a threat. Now, the fact that this is made a scary thing, it means that there's some punitive tone to it that is going to be attached to it. So therefore, it's a big stick that I'm going to beat you with because I am going to report you, Even sometimes when it's not even relevant at that time, might be doing something right that might not agree because we have some competition on the road, agree, like because you don't agree, now I'm going to tell you that I'm going to report you, So I wish there can be a way that can remove the punitive tone to it, that if we are reporting this, it's because it's a punitive measure, but we are trying to do quality improvement and ensure there's clinical practice that is the best. And also, I think it goes back to your question, Elias, in terms of the CBDs. So that can actually inform the CBD area that one has to highlight, both at organizational level and secondary to the HPCSA level. Because they can say, okay, there's a lot of reports around the usage of Pentrox or whatever kind of medication. Therefore, let us then write on a newsletter like this and say, let's address this issue. Pentrox needs to be used like this, or change some things like that. So I do think that it's something that goes 2 ways. I do think that the HPCSA is not the only person. I think actually the organizations are supposed to be doing it, but they need to be on top of it, ensuring that people are doing their CBDs and also the clinical case audits in terms of ensuring quality assurance.
Yeah, no, thank you for sharing that bit, Malusi. I was just going to move on to the next one, which is going to be the
Sorry, Elias, before you
Yeah,
move on, sorry, I just want to redeem myself there. Is that I've gathered my thoughts a bit.
go for
You
it.
know, as part of that document that was published, there's things that they mentioned is that the communities or the public that we serve or the public that seeks emergency medical care is continuously changing. And how you need to understand what is it changing. Back then, and I'll make an example, back then when we were still young, I'm sure in Namibia and so in most countries, in African countries or most places, is that there were not a lot of fast foods. People were not living a sedentary lifestyle. People were much more active. And there was the burden of diseases now is increased. People are living a sedentary lifestyle. There's less people that are exercising, but also the non-communicable diseases are on the increase, which brings the change in communities. In addition to that, is that when you look at the healthcare technologies, the stuff that we used to practice with 10 years ago. By the way, I'm 13 years into the industry. I'm not a dinosaur like Malusi, but if you look about it, the healthcare technologies, the practices that used to be there, and the standards of assisting these communities have also changed. So now, as practitioners, we need to understand these changes. We need to appreciate these changes, but also we need to keep up with the changes that have been brought, and therefore continuing professional development needs to be there as healthcare professionals to remain relevant, to make sure that people are safe when we're treating our patients, but also we're engaging with those communities that are concerned. However, we also need to appreciate that there's barriers to doing CPDs. And what are those barriers? Some people cannot afford.
That rooster is just letting its thoughts known as well. Whatever it
Yeah,
said, it matters.
I've got more than 20 roosters.
the
Roosters'
roosters
lives matter.
agrees with me. The thoughts are valid. But anyway, is that we need to appreciate that CPD activities, although it's individual, but it can be expensive, which can be a huge barrier to practitioners acquiring that. But also, as I said earlier, is that, and this is something that is also in the document, is that also as part of the barriers, some organizations cannot provide CPD activities for their employees. So I wish that can be a platform whereby people will be able to do them free for everything that they need. However, it's not possible.
Yeah,
So
but I
yeah,
also think that, if you want to practice, if you want your clinicians to be up to date, you should somehow create a platform for them to
as an
continuously.
organization.
As an organization, I think so. Sorry, Malusi, you were just about to say.
Yeah, I was gonna say there on page. What page is this? Page 5, paragraph number 3. It's 1, 2, 3, 4. Paragraph number 4. It says that although CBD is considered in both formal and informal context, individuals are encouraged to have a structured approach to their CBD activities. Generally, this involves 5 steps: self-appraisal, a personal plan, action or implementation, and documentation and evaluation. Basically, those 5 steps need to be there. Basically, the organization needs to have something that is similar to that. Firstly, it starts with you, self-appraisal. And then, number 2, your plan as yourself. Yeah. And then after that, you take action or implementation of your plan. And then you document what you've done and evaluation. Basically, that's what it said. So yeah, it's up to us as clinicians and organizations to ensure that we have those systems sorted.
Yeah. Talking about CPD and professional growth, 2025 HA guidelines are out. Make sure to read them. Make sure to stay up to date and informed. I saw a few people making memes out of them already. Yes, because of
Yeah.
Lucas devices and so forth.
Yeah, there's a whole lot of stuff. I've seen a lot of arguments on LinkedIn, professional doctors and people arguing Europe and America. So it's interesting. I haven't engaged fully, but once I give myself time, I'm gonna engage and see what's
I
happening.
think we should cover that on the Para podcast just so that we share with people as well what's going on there. But just moving swiftly on the document, I think the next part of it was the clinical decision tools and the clinical practice guidelines. I think what they have provided here is just a little bit backdated. because it was speaking about the document being reviewed, which was presented in 13th of June 2024 by the board meeting. And they did say that they did consult few stakeholders and that they are expecting all 23 of the clinical decision support tools by the end of the year, which I'm guessing is 2024. But there's a link there at the bottom of the page. I tried going to the website to see if I can see this clinical decision support tools, but I could not find anything. So I'm not sure if you guys saw them or if there's anything in 2025. I don't see anything on here as well. But do you guys want to make a comment on that?
I think you've seen it, Elias. I think we once spoke
It's
about
the
it.
one
But
the one that we shared.
yeah. So it's the same one there. I think
Amazing.
Tulan has much to say about that comparing to me.
I think it would have been nice if they've to have included it in this document as well to say, this is what is out. This is what. Yeah, I do remember seeing it because I think we did review it because I think even one of the comments that were made here is that the clinicians did complain about the length of the document and that it was difficult to digest. I guess
Yeah.
not everyone is academic. It should be appropriate for practitioners.
Yeah. Look, sorry, adding to that, yesterday there was a conference, at the EXA conference, and I got distracted when Dr. Soboa was talking. And I do remember hearing a little bit that he was talking about something that has to do with it, the document. But I'm sure there's a lot of updated information that he might have spoken there. So this document, as much as it was published last month, it might be a bit outdated towards the HPSCA is up to at the moment. I think I remember him talking about the IT systems and how to make the document user friendly or stuff like that. But I wasn't really paying attention. I had an unplanned visitor that just popped in while I was busy. It's when you're on holiday, everyone knows you're on holiday and they come and visit you and have a chat.
Gentlemen, Tulani, do you have something to add before we go to the guns?
Look, for me, wow, this sounds wrong. Which guns? These ones? I'm just asking. Look, Elias, I'm for support for the clinical decision tools. And when you been in the healthcare system, especially in the South African one, where we come from to where we are now, I think the clinical decision support tools are very true. Obviously, with the comments that people have made, it will be refined because this it was us is understand that the cases that we go to, be wherever we are, some of them they critical, and sometimes you've got high cognitive load. And in order for you to not make decisions that will affect the patient's life, you need to make decisions and you need to reduce that cognitive load. So there are studies that are being done to say how to reduce cognitive load by also having places where you can refer medication doses, what's the best treatment for this patient at that moment in time. So the clinical decision tool that has been developed by the HPCSA that was released, it looks much better, and I think it's good for the practitioners and hope they use it. Also, I've seen that there are some private providers that are printing that clinical decision tool for emergency care providers so that they can have it whenever they're on scene. They can reference to it. That will assist them when they're on scene. That will ensure that the practitioners are making good decisions when they're treating the patients and they look at the best possible outcomes and they incorporate the clinical decision tools, incorporate the latest treatment guidelines and also evidence-based. So I am in support of that. And I hope that even though the document is backdated, we hope that practitioners did comment on it as they were encouraged so that they can modify the tool to best meet the needs of the emergency care providers, and also then it will eventually benefit the patients that are out there. I hope that as part of the modification, and this is based on my experience now, is that ideally we're moving into more a digitalized world whereby you have everything in your hand. A book is great, but a book can be lost. But what we always have in our hands is our phones,
Digital
and
books, yeah.
you can always have a look at that. However, depending on wherever you are, sometimes you can't just take out your phone and look at it. Depending on the settings, whereas a book might be appropriate in the setting that you're working in. But yeah, my thoughts is that in support of the clinical
Yeah.
decision too.
I know Tulani made comments to the board about the clinical decision making tool. Thanks for representing Tulani. We do need people that talk and say what they think and actually engage with the document. Having said that, my last line would be congratulations to the HPSCA board to actually do that. And also considering that the last document that we actually had in South Africa was in 2006. And then to think that then years later, then they were able to do that one that came out this year. It's actually good. Uh, I don't know how we can ensure that we're on top of it, that we update everything as it should, as it continues, so that we don't have that big gap in terms of the information that is what is that the practice that is best practice as compared to what was done back in time. I think we do need to have some systems of updating that. That's why digitality of the document is actually something that is highly recommended, because you can just update it and everyone will be updated, as compared to having a document that was printed in January and then by the end of December you have new American Heart Association guidelines that have changed, then you have an old document. Whereas if it's digital, you can just and then sort it out. Yeah.
Just one last thing, Malus, is that no board is coming on board. I don't know if that makes sense, but there's a new board
Yeah.
that will be coming soon into the HPCSA. And I hope that there's going to be a smooth transition between the old board and the new board, in order to also to carry out the duties, because there's a lot of stuff that they've done. There's a lot of progress that the old board has done that has progressed to where they are now. And if the new board takes over, they're supposed to carry that and obviously bring more ideas that will enhance the profession as a whole. Whereas if there's no smooth transition, then it's going to put us backwards, you know. I mean, it's things that we've discussed on the podcast. The clinical decision tool is one of them, but also the progression of the courses that we're running, something that Dr. Lloyd has highlighted with the rescue and changing or updating the curriculum of the program. With the new board coming in, we hope that those are the things that they'll address that was started by the old board.
Yeah. Well, thank you, gentlemen. Just moving on to the next one because of time, is the most, I think, debated topic. Should the emergency care personnel be carrying guns or firearms? And I think I just wanted to read one of the paragraphs in the paper, and it says, arguably, South Africa has one of the highest crime rates in the world. And emergency personnel often find themselves in dangerous situations where they are targeted by criminals. Given the threat of violence, emergency personnel may feel safer carrying a firearm for self-defense, especially in volatile areas. However, the carrying of a firearm may increase rather than decrease the chances of becoming a victim. Now, I have my thoughts on what I think, but I wanted to find out. Obviously, you guys from our background chat, you have mentioned that this is not the first time this concern is being raised. Unfortunately, I have not worked in South Africa. I don't really know what the crime is like, on the ground as compared to you guys that have. What do you guys think? Do you think you feel threatened to such a degree that you somehow need to carry some form of protection for yourself in case the first line fails? Or do you think the measures in place currently are adequate to protect you to carry out your roles and your duties and responsibilities?
Sorry, Elias. Can I give a bit of a background check? It's a bit of a
Yes.
history lesson.
Grootman,
Tina.
dinosaur. Yes.
If the shoe fits, I'll wear it. Right. So basically, it's important to understand for the international audiences that might be watching, because sometimes it can be through TikTok and they just have a synopsis of what is happening. South Africa is a country that has a very ugly past, right? From back in time, there are a lot of wars that were happening. In the recent histories, possibly would remember the most popular ones. I'll talk about 1976 student uprising, where you have a lot of violence that was happening. People that were born at that time, they're now in their 50s, or that were active, or that were born around their 50s. And then you'll have people, and then you have the Sharpeville massacres and all that. Now, those are big events that happened. Even where I am right now in KZN, there was a lot of violence. There was a lot of people that were killed during the apartheid and even during the transition towards the new government. So, talking 76 until 1993. It was very hectic. It was a lot of people that are dying, such that you'll have communities and families that had guns in their family. So whenever there is a crisis, they have gun stashes that are just somewhere there. They know that if there is a crisis, and they use guns. That's why you also have things that are called inqabis. So those paid assassinators, people that actually kill people, and that is what they do. It is something that if you Google it, you'll see that it's something that is out there. So violence is something that is somehow embedded in the history of the country. Therefore, violence is something that you see in the population. It's easy if a person does something wrong, can be beaten up hard. And so you as a clinician working in that area, is that mentality that you must understand that there is violence that exists. So guns are part of the society. It's easy to see, not like in America, but they have a lot of illegal guns. So while you're working on a patient, it's likely that there'll be a person with a gun that'll be walking around, right? Or a gun will be pulled out on you while you're working. Therefore, it becomes a bit dangerous. There's a lot of research internationally about the risk that paramedics are exposed to, or clinicians that work in the ambulance are exposed to. Might not be guns at that level, might be assault, might be stabbings, it might be patients that are verbally abusive, sexual assault, and stuff like that. But in South Africa, we're talking guns because there's strong violence. That context of violence and using guns is there. So therefore, that is why there's a talk about guns. Now, for a person like me who knows, I was young in the 1993s and
With hope,
1994s.
with hope.
But because my mind was orientated in terms of politics, I am alert that guns were involved. I know that guns were involved, and I know that people were shot. Possibly might have seen a person dead at that young age. I don't like guns. Now, to think that as a person that I am, who is working with the population that I work with, now I need to carry a gun for my safety. It's now I don't like guns. I don't have a gun, and I don't like guns. Just don't see myself with a gun, because I look at it as something that is violent, aggressive, and it's a lethal weapon. It's there to kill. So it doesn't really associate with me and the person that I am. Having said that, what do you do that though? If you are
Protect yourself.
faced, yeah, what do you do to protect yourself? That's the question that is out there. What do you do? Do you just hope and pray that you are okay? If a person pulls out a knife on you, I remember at some point, I remember working in Soweto before I left, just before I left. A young man, possibly 17, he shot his friend, and another friend shot him. They're drinking. Don't ask me how they got the guns. And one died, so I did life extinct on the other one and then transported the other one. Life extinct declaration of death. And then I had to transport the other one to hospital. Now, understanding that he was drunk, he kept on fighting with me at the back of the ambulance. I had the IV line, I had oxygen on him. He's fighting. I understand that there are guns around, but I need to treat him. It wasn't very far from the hospital. But I remember being triggered that I'm irritated now. Why is this guy fighting with me so much? And also in my head, there is that thought process that says that this person actually just killed his friend now. So basically, there is that moral dilemma of a person that has committed crime, right? And also I am there. There's a gun there somewhere in the house. Then we're transporting him. We got there. And as soon as I got him there, kept on fighting with him. I'm alone at the back of the ambulance. As soon as I got him there, the doctor looked at him once. He said, patient has tension pneumothorax. Right on my stretcher, did the formal chest drain out, and then did the x-ray afterwards, checked it was in the right spot. The patient was calm after that. Now, I want you to think of a lot of things around this case. Number one, moral dilemma that I'm faced with, right? Number two, I'm vulnerable. And then there's cognitive load on top of that. I did not recognize that the patient had a tension pneumothorax, but I was fixated in the fact that the patient is violent and he's drunk and he's a bad boy. Now, what do? Do you want to have that cognitive load as a clinician? Is that the space that you want to function in, where you can decide, you know what, this person is irritating me, I'm going to pull out a gun on them. Now they become your victim. Yeah, it's just too much. I don't know.
Yeah.
You,
I
you
think
guys can tell me what you think. I've
there's
said a
also
mouthful.
Yeah, there's also that aspect of you that is having a little bit of the fight and flight in the background, just ready
Mm.
to step in because obviously of what you've witnessed. So I do appreciate that it must be a lot, and it affects your ability to render the care that you are there for. So the question is the system protecting you well enough? Doesn't sound like it, because then if there should be police, is police there? Then are you, do you withdraw from the scene then? Or do you still proceed? Because especially knowing that this person's life is in danger, or whatever the case might be. But Tulani, what do you think?
So thanks, Grootman, for the history lesson.
Okay,
Look, Elias, South Africa is a beautiful country. I love home. There's no place like home.
that's why I'm here.
There's no
Roosters.
place like home. And I hope this doesn't paint South Africa as a bad picture. But we also need to understand that. And if you look at the world stats, according to the world stats, is that in about 193 countries, I think, South Africa ranks 7 in terms of the crime stats. But you can dive deep into that to find out more exactly. But understand that with the history lesson that Malusi has given us, is that the crime and violence has always been there, has been there for years and years and years and years and years. And with that is that there's been an increase on the attacks of EMS personnel in various forms, either verbal abuse, physical assault, or even organized attacks with criminal intent. I mean, I remember, sure, guys, that was my first incident. I was still used to work for a private company. We transported a patient from Northwest to Joburg. Although I'm from Joburg, I was still naive. There was a GPS that was left in the window. We took out the patient from the ambulance. So those who know at Krugersdorp Hospital, it's a Netcare private hospital, took out the patient from the ambulance. We locked all doors. The GPS, obviously, when you switch off the car, it switches off. We handed over the patient. When it came out 30 minutes later, the window was broken, the GPS was gone. So that highlights that organized crime with criminal intent is something that was there. That was, I think, 2013, that was still new in the profession. However, the crime, the verbal abuse, all of the stuff that I've mentioned is forever on the increase. And understand that although we're making these comments, I'm not an essay to give appropriate of knowledge of what's happening there. But from my understanding is that some companies or certain emergency care providers still do not feel protected. One, because of they still go to those scenes. I don't think there's my understanding of what has been explained is that when they go to those cases, they get sent and then they'll say maybe police escort will come or wait for a patient at a specific place. Or when those go to those places, it's dark, it's not safe. And understand that, how can I say that? Is that you need to understand is that with, and I've said this before, is that we need to appreciate the EMS system that exists in South Africa. It's unique compared to the rest of the world and some of the other African countries. Is that EMS system in South Africa has private and government. In the government, in the private sector, and I speak, this comes from anecdotal experience, is that the private sector would never send me to cases or places where it was never safe. Whereas in the government sector,
Really?
they do send patients, I mean not patients, they do send emergency care providers to places that are not safe. But do they know that the places are not safe? I'm not sure. Maybe it should start from the screening of the calls to the cases where the patients are to the where the paramedics are going to. But in essence, I do feel that certain companies do protect their employees from such incidences by ensuring that those safety measures are there, making sure SAPS is there. If SAPS is not there, or if it's not safe for the paramedics to go there, paramedics don't even go there. Obviously, if that approach is applied across the country, who's going to suffer? It's the patient themselves. We can't have these situations where we have our own brothers and sisters being subjected to violence, crime. Sometimes it's difficult to even know. I mean, in certain cases, people are subjected, they want their cell phones. There's that, they call ambulance just to rob the ambulance providers or emergency care providers.
Yeah. There's something I want to add there, Elias. a current acting district. Wait, let me read it properly. How his title is before.
Are you able to
Um,
share it, Malus? I can. Oh yeah, but continue. We'll share it later. Yeah.
he posted something that I found interesting. I'm gonna tell you his title just now. He's the acting operations manager for Gauteng Department of Health. So he's looking after EMS at the moment. I know Mr. Stolle very well. He was my principal at some point. I was working as a lecturer at Lebone. He was acting, was involved. He was also involved in the transaction of Lebone engaging with Sefago Makgatho University to have that diploma course at some point. So he's a person that has been involved in a lot of stuff in EMS. He's written a a post that I found very interesting. I'm not going to read everything that is there. He said there's a gap between theory and reality. I think it's something that we've seen in research. He's done stuff that has to do with the violence of the practitioners. And also I've done stuff that has to do with violence to myself for my
Even
master's.
Yasin Hockey.
Yes. There's a whole lot of stuff that is done. Actually, there's still more that is being done. I remember someone saying at the conference, XR conference yesterday, that they're doing research that is in that space. Says that SAPS sometimes may take between 40 and 20 minutes to arrive on scene. You have a person that has been assaulted, 40 and 20 minutes. So that basically is not going to work, right? It doesn't work. So they've tried it. They've been doing that. And then there's also this idea of hotspots where you meet up. I think you've mentioned it's there to learn too. Hotspots where you meet up at a certain point and then you go to the patient's house. That doesn't work. Sometimes you have community, policing forum. You meet with them at some point. Sometimes that might work, but also it still delays the patient care. He also mentions that there might be a quiet street that just erupts to violence. So you can't have a hotspot there. So violence can be anywhere, anytime. And also there is the risk of morality and policy gaps. He says that, I'm going to read this as he says, declaring EMS zones as gun-free without providing real-time protection shifts the risk entirely onto the individual medic. And if we can't guarantee their safety, we are ethically justified in denying them the right to self-defense because they are the ones who are at risk. So now we need to think about those things. What exactly are we doing? Like we talk about this, I think the government, especially in Johannesburg, I know that they've tried to use these systems where they involve the police, they try to involve the police, the resources of the police are stretched, but they can't do it, you know? So it's a complicated situation. It's really a complicated. And he also mentions things like pepper spray, body cams, combat jackets, and stuff like that. They've explored those ideas, but it's still, you can't fight a pepper spray with the person as a gun. You know, you're just making a situation worse. A camera is going to be there. It's going to capture. They don't care, these people, you know. I think it's hard to also test it somewhere using research because it's a bit of a unique situation. You can test it in America because they like guns over there. In terms of the other uh, um, American or Australian researchers that are out there, this is a bit different. Like the guns are not as crazy as it is. Even in New Zealand, it's not the same. The guns are not as crazy on the streets as you have them in your places like Johannesburg, Soweto, and KZN and stuff like that. So it's a complicated situation. I find myself not knowing exactly what to do. I
So
think the society needs to change. That's what we need.
So Elias, I know we're running out of time. Just from my side, just quickly, is that obviously because of the time, we're running out of time, is that people should read that document on the strategies that have been highlighted by the HPCSA, but understand that it's a multifaceted problems that involves different bodies, the SAPS, the emergency care providers, also other measures, education and training or education programs to educate the general public. So all of these things that need to be looked into. So it's not as simple. There's no one simple solution, but also it's unique to the country that people live in. So yeah, I think the main take home message is that the South African government is tackling attacks on EMS personnel through stricter legal penalties, community education to build trust with the emergency care providers, and they're trying to improve the security measures as well as infrastructure, high-risk areas all of these are aimed to create a safer working environment. My last comment is that people that see this, please comment on this. How is it where you're working? Do you feel safe? Is it how do you find working wherever you're working? Yeah. Thanks, Elias.
Yeah.
I think Elias, we should get Dr. Chikane to come and discuss this with us thoroughly,
Yeah.
because
And
it is topic of interest.
and
That's an invite, Dr. Koza. Please come. I know he's gonna come. He's a good guy.
yeah, and discuss it in detail and see sort of just perhaps closing off, right? If you can just wrap this up, and I know I'm trying to compartmentalize this, but if you
English.
had to say one word, right? Not one word, one thing that could be done to make, obviously, given your current experience as to where you're working, how can we make EMS or the operation of paramedics in South Africa safer? Just a very succinct, short version of your thoughts. Let's start with Malusi.
No pressure, Malusi. And thanks for that, Elias. Thank you.
That's impractical, bruh.
Just
But
a
I'll
very
say
short
this.
version. Yeah.
I think we need, by providing guns and providing security measures, we are not necessarily treating it's a silent symptom of a societal problem. The society has to change, and we need to find ways, not as EMS, as just a society, to become better people. We shouldn't be treating symptoms of a crisis. This violence towards people that are helping the community is just plain responsibility. The moral fiber that should be worked on is the society. I believe that's what should happen. Not only in South Africa, even in the developed world, in Australia, in the UAE, wherever there is violence, wherever there is a paper that has been published that talks about violence in that community, that should happen.
Because your question, the way you asked it, Elias, I'm just going to be smart, like Malus when he's wearing glasses. I'm not saying he's not smart when he's not wearing glasses, but because you said, what's one thing? In adding to what Malus has said, I think it goes beyond that. We need to also maybe, as I said, it's multifaceted. There's no single solution to it, but also when it comes to the call screening, the calls that come through the call center, the call takers, the call dispatchers, they are the ones that send the emergency care providers. They can also have an insight to say, okay, this is a high risk area. Can we send our practitioners there, and also to alert them to say, okay, this is this type of call that you're going to. How can we mitigate this? So it goes. It's not a simple solution. I think your question is unfair, but to add on what Malusi has said and the clinical practice document that is released by HPCSA, it's a multifaceted problem, and that requires multiple solutions at different angles to try and mitigate the safety. I mean, the private sector can learn from the government sector, and the government sector can learn from the private sector to make it safe for emergency care providers. It should be collaborative from all stakeholders. Yeah. And also the fact that we are talking about this, I hope it will trigger the dialogue, the conversations to try and make sure that they implement those. Yeah, that's
No,
2 cents.
And I know I'm sure you guys have more to say to this, but I'm sure I will dive deep into this topic at a much later stage. But thank you to our viewers. Thank you to everyone that follows the podcast. We really appreciate you. If there's anything that we can do to improve the podcast, or you have any suggestions or any guests that you'd like us to invite, please reach out. Let us know. Send us an email. Make a comment on our TikTok, on our YouTube channels. We'll be very happy to have those. Calling out to anyone in Botswana, if you want to, come chat to us here, because you guys are giving us so much love. Would love to have you.
Boitumelo, people.
Yeah,
There's a post in Boitumelo. Yes, they're looking for a PhD candidate.
Boitukanelo.
That one. We say
Boitukanelo.
Boitukanelo. Is it right?
Yeah.
Yes. They must come. Also, apply on the post. They're looking for a PhD candidate. No, yeah.
Yeah. All right. Thank you very much, gentlemen. This is it. And thank you to everyone that's watched our podcast. We appreciate you. We are out.